joined.
So the live streaming started or? Join?
Yes, ma'am. Live stream start. Yes, ma'am. It started.
Started. Okay. So now it's 7:30. Shall we start the program?
Yes, absolutely.
Professor, are you there?
Yes.
Shania, now the certificate is visible. Okay, we'll start the program. Okay, Sudeep sir.
Yes.
So respected President Sudeep sir, President-elect Dr. Rupesh, then all executive committee members, the department heads from various dental colleges, faculty members, dear postgraduates, a warm good evening and warm welcome to all to this program. Actually, we are really honored to have the members from Federation of Special Care Dentistry, that is Secretary Dr. Priya Verma, Chairperson Dr. Manu Reddy, Co-Chairperson Dr. Vinaya Kundapur. Welcome you all to this program and thank you for joining. I adorn the presidential collar on President Dr. Sudeep.
Thank you, Dr. Manju.
Actually, we are really fortunate to have Dr. Smita, an eminent academician with us. Her commitment to geriatric population is really admirable. Then we have Dr. Shyam for moderating this session. So once again, warm welcome to all to this program. Welcome.
Yeah.
Then I request Dr. Sudeep to do the presidential address.
Let me take this opportunity to welcome all the IPS Kerala State, all to the IPS Kerala State Branch Web Talk series. The respected speaker, the scholarly person in the field of geriatric dentistry, former Joint Secretary of Geriatric Society of India, Pune chapter, Dr. Smita Tavale, and today's moderator, Professor Dr. Shyam Mohan, Professor PMS College of Dental Science and Research, the leaders of IPS Kerala State, all respected HODs, live members of IPS Kerala State, and the most beloved students. Topic of the day is the role of geriatric dentistry in clinical prosthodontics. The proportion of the elderly population in India has increased drastically. 80 to 90% of the adults face oral health problems in this situation. Those most respected persons need specialized care that takes into consideration the unique needs. So today's topic gives all of us a deep knowledge on how geriatric care is well delivered to the needy. IPS Kerala State humbly recognizes the presence of Dr. Priya Verma, Dr. Manu Reddy, and Dr. Vinaya Kundapur, who leads the Board of Geriatric Dentistry in India. I once again welcome all the delegates to this well-informed presentation of today. Thank you, Dr. Manju. Thank you. I hand over my mic to Dr. Manju, please.
Now I request Dr. Rupesh, our President-elect, to introduce the moderator, a very knowledgeable person and a great orator, Dr. Shyam. I request Dr. Rupesh to introduce Dr. Shyam Mohan.
Thank you, Manju, and a very warm good evening to each and every one of you. And let me once again welcome all of you to this exceptional webinar series, a special webinar series for today, probably on a topic that is not being even the importance that it deserves, the role of geriatric dentistry in clinical prosthodontics. And we have an authority like Dr. Manju and Shyam was saying, our President was saying, Sudeep was saying, an authority in this field, Dr. Smita Atwale, a very, very dear friend and an exceptional speaker. It's also really happy and gratifying to see our dear friends, Professor Dr. Manurati, who's the chairperson of the Federation of Special Care Dentistry. Welcome, Dr. Manu. So good to see you. And also Dr. Priya Varma, who's the secretary, and our dear friend Dr. Vinaya Kundapur, all have joined in. So before I go into introducing my very dear friend, Dr. Shyam Mohan, who has consented to be the moderator for today. Friends, today, September the 22nd, you should know that it is International Centenarian Day. Centenarian, as you know, are the epitome of geriatric population who have crossed 100 years. So today happens to be International Centenarians Day. And just yesterday, as many of you know, September the 21st was World Alzheimer's Day. Again, a situation affecting the geriatric population. So today, as we host this webinar along with the FSCD, it is all the more important that this particular topic is discussed today, as these two important dates falls today and yesterday. So it's really happy that we are hosting this webinar series on the role of geriatric dentistry. And to introduce Dr. Shyam Mohan, as as the saying goes, Shyam probably doesn't need much of an introduction, especially in our part of the world. And those who know him very well, he's an exceptional teacher, a very committed teacher. He has a lot of accomplishments as an academician. He's won the outstanding teacher commendation from the Raja Central College, and he is very worked previously to his current position. And he is a PhD guide in Prosthodontics for the NCR Medical University, Tamil Nadu, the PhD board member from the Vinayaka Mission Research Foundation, Salem. He is the associated editor and reviewer to the Journal of JIT, the Journal of Indian Prosthodontic Society, reviewer and been editor for various specialty and dental journals across the country. I've known Shyam for close to more than 2 decades, I think.
Yes,
and Shyam, other than being an academician, he comes across as a very, jovial. He passes on the message that he wants to convey in a very subtle and a humorous way. He is a man with an amazing sense of humor in him. So that makes him, very listenable and acceptable as a speaker. And, the big fan of students community that he has around him, speaks volume of the way Shyam has been, with his, very mild demeanor and his subtle sense of humor. He is also, dear to all of us in Kerala, IPS Kerala. He has been the founder, quiz master of the prestigious IPS quiz contest. We call it Quest. So Shyam has been the inventor behind the innovative way in which the quiz was conducted. And in the coming year, a big celebration is going to happen in PMS, on which Shyam has told me to invite all who have gathered here. Next year is a Silver Jubilee celebration as a teacher, 25 years. So there's going to be a full day, celebration. So all of you who are listening, please wait for Dr. Shyam's invitation to be part of that big celebration on a Silver Jubilee of attaining, the prestigious, exceptional teacher position. So with these few words, ladies and gentlemen, may I introduce our moderator for the day, my very dear friend, Dr. Shyam Mohan. Shyam, the stage is on.
Thank you so much, sir. Lovely introduction, as always.
Now I request Dr. Shyam to introduce our eminent speaker, Dr. Smita.
Yes, it's a pleasure.
Please.
Dr. Smita Atwale, a long-time friend, an astute clinician. We know for the past, I think, probably 10 plus years now, Dr. Smita.
Yeah, absolutely. More than that. More than that.
Yeah, so it's absolute pleasure to introduce Dr. Smita Atwale. She has got 22 years of experience as professor, PG guide, and PhD teacher in D.Y. Patil Dental College, Pune, India. She is in private practice restricted to prosthodontics, dental-facial rehab in Pune. She is consultant maxillofacial prosthodontist, geriatric dentist, and founder member of Cleft Care Center in Dinanath Mangeshkar Hospital and Research Center, Pune. She is member of editorial board GIPS. She is a founder and executive council member of IPS Pune branch. She is from a joint secretary of Geriatric Society of India, Pune chapter. Dr. Smita is member of Geriatric Board of Federation of Special Care Dentistry. She has completed a certification course in geriatric medicine conducted by Geriatric Society of India. And she has had scientific papers published in national and international journals, being guest keynote speaker at national and international conferences, and now a known figure in geriatric dentistry in India. So here I present Dr. Smita Attavale for all of you. Welcome, Smita. The podium is all yours.
Thank you so much. Thank you.
A small bit of information for all the people who are listening both on Zoom as well as YouTube. I request all of you to kindly mark your attendance. All of you have registered on our Google form, but I request all of you who have logged in to mark your attendance by commenting your name on the inbox. All of you are on YouTube and as well as here, please comment your name on the chat box.
Yes, sir. We have their mail IDs, but it's better to write their name. That will be better.
We will not know who have logged in.
Okay, ma'am. The podium is yours.
Thank you. I'll just share the screen. Manju ma'am, can you see the screen? Rupesh? Dr. Shyam sir?
Yes, ma'am. It's clear.
We can.
Okay, thank you so much. So, first of all, thank you for such a nice introduction, Dr. Shyam Mohan sir, and most important, to pronounce my name and surname absolutely perfectly. I think you asked me then when we were,
Yes.
chairpersons for a session, and you wanted to know how to pronounce it, and you have remembered it.
Yes, exactly.
Really, hats off to you, sir.
Thank you.
Thank you so much.
So I didn't have to double check with you today.
Absolutely, absolutely. You have remembered it.
Yes.
Thank you so much.
My pleasure.
And today, first of all, I would like to make it very clear. Though I'm a prosthodontist, today I'm here as a geriatric dentist. So it's a geriatric dentist who is, trying to share some experiences. I'm not saying that I'm an expert or, any stalwart or anything like that. But this is all my 25 years clinical practice and working closely with geriatric patients, because I'm attached to a multi-speciality general hospital, and a lot of geriatric patients come there with various needs. So, I see day to day all atypical cases, and that's why my lecture would be less of technically centered. It's not going to be like that. It's going to be patient centric. The theme is going to be the geriatric patient. So let's all be receptive. And I have received a lot of questions by Dr. Manju. Let's hope that I present my, talk in a limited time that has been given to me. Otherwise, I tend to go on and on. I just warn you. And I have Dr. Shyam sir, I request you to please let me know when my time is over. Just give me a 5 minutes heads up. Yeah. So
Sure,
that,
yeah.
Because as I was telling Dr. Manju, some topics may go on and on, some topics are topics within themselves, big lectures within themselves. So it's very difficult to cover everything. Let's treat this as an introduction to geriatric dentistry for everyone, especially for the PG students who have joined today. So a big and a very hridayasparshi namaskar from Pune. It's a Ganesh festival, Ganesh Utsav for us, and it's a very big thing in Maharashtra. And today, especially, I thank Manju ma'am for choosing this day because it's our auspicious Gauri Pujan day. And I'm really, really very happy to do this presentation on this very day today.
Thank you, ma'am.
Yeah. And this is something which Dr. Shyam sir has already very nicely said about me. So I'll skip this. And let me talk about my parent organization. Yes, the Federation of Special Care Dentistry, FSCD as it's called. FSCD deals with all the patients who need special care, be it a geriatric patient, be it a pediatric patient, all patients who require special attention, special care, special method of treating, they are all under the auspices of Federation of Special Care Dentistry. Board of Geriatric Dentistry is one of the many boards that Federation of Special Care Dentistry is having, like cleft lip and palate, or autism, or cerebral palsy. You know, there are so many boards that are there, and we are a part of it. Board of Geriatric Dentistry is part of it. And what we are trying to do here is, sensitize. First of all, our task starts at sensitizing people towards geriatric dentistry. Let them know the importance of geriatric dentistry. Let them know that it is very, very different and little difficult to manage geriatric adults. It's not the same as managing any other adult patients. So Federation of Special Care Dentistry holds some community outreach programs also. We hold continuing dental education programs also. And we have participated in, the Special Olympics Bharat that we had. We examined, we were the people who were examining all the special athletes in this program for their oral screening. So with these words, I appeal to you all to be part of this movement of geriatric dentistry, be part of Federation of Special Care Dentistry. Thank you. So this particular interesting slide that I got from my friend from Kochi, Dr. George P. John, that day he said, see, Smita, you are taking a lecture and there are so many such billboards coming up in Kochi. He said there may be some in Pune. I said, yes, absolutely. I see such boards in Pune and we have never seen them before. Why? Because the number of geriatric patients, the elderly patients, and their needs, their requirements is slowly coming to the forefront. Currently, 10% of our population is more than 60 years old. It will be 22% by 2050. Why I'm saying 60-year-old over here is because in India, we treat senior citizens at the age of 60 years. In different countries, it is different. For example, in USA, it is 65 years and above. In Japan, for that matter, it is 78 years and above. So let's stick to Indian standards. And when I refer elderly, I would always mean 60 years and above. Thank you for that photograph, George. So let's peep into geriatric dentistry. What is geriatric dentistry all about? In my presentation, some of the words I will be repeating some, as they say, 10,000 times. But when I repeat the words so many times, please understand that the word is that important. So the first important word today that you all will remember is multidisciplinary approach. Geriatric dentistry is a specialty in dentistry that involves multidisciplinary approach in evaluation of oral health, diagnosis, prevention, and treatment planning for senior citizens. As I said, I'm saying about 60 years and above as per Indian standards. It also deals with the dental treatment for elderly and or medically compromised patients. And its scope extends to providing palliative treatment and symptomatic relief from oral health problems like mucositis, xerostomia, dental caries, chronic periodontal problems, etc. That means even if you cannot give the ideal and 100% treatment to the geriatric patient because of a lot of limitations that the patient may have, but you can certainly make their life more comfortable by offering them palliative treatment and symptomatic relief. So there are multiple geriatric dentistry definitions that you will see, thanks to Google Baba, in like an old lady, let me say, that in my era, or when we learned, there was no Google Baba. So, we used to go through the journals and, talk to our teachers and try to get information from the seniors. But thanks to Google, there are a lot of good things also you can take from there. I came across this definition of geriatric dentistry, and I found it as an ideal definition of geriatric dentistry. As I said, that's my choice. There are other definitions available. So geriatric dentistry or gerodontics is the delivery of dental, I would correct it as orofacial care, to the older adults, involving the diagnosis, prevention, and treatment of problems associated with normal aging. Mark the word here, normal aging. It's not just pathology, it's physiology, and age-related diseases, and as part of an interdisciplinary team. This is a very important word, as I said. Multidisciplinary approach, interdisciplinary team, these are keywords today, with other healthcare professionals. So now you realize we have to practice geriatric dentistry with the help of other healthcare professionals, like other medical and paramedical branches that are there involved in geriatric healthcare. So, imagine the dentist or the prosthodontist, if you want to say, imagine ourselves as traffic police. Why? Why traffic police? Because geriatric patients come to us, or they are referred to us for removal, restoration, or replacement of teeth. What happens is we diagnose, when the patients come to us, we diagnose the existing orodental problems and guide the patient towards complete oral rehabilitation. That is what is expected, not just the treatment that time. Of course, we will give the treatment what is required that time, but also we will lead the patient to a complete oral rehabilitation. We have one more responsibility. We identify the oral manifestations of systemic disorders, and accordingly, we guide the patient to the physician for the needful treatment. That's why the role of traffic police is very important. Some points to ponder. As I said, in geriatric dentistry, all the branches are involved, and community dentistry or public health dentistry is not, an exception. So we have to deal with socio-economic issues. In a third world country like us, the financial problems, the economical limitations that the elderly face, the disabilities of the elderly, because of which they cannot come to us sometimes for the treatment, medical and health issues, their diseases, sometimes one systemic disorder, sometimes multiple pathologies present. Most important thing, sometimes many people have expressed this to me, and it's very disheartening to pass a remark, the treatment of the elderly like a big headache. I agree there are some behavioral issues, but exactly like pediatric dentistry, we have to understand, what problems they are having, and we should understand to deal with them, and in spite of those behavioral problems, provide them with the correct treatment. And oral health related other issues. These are the few points to ponder that, as geriatric dentists, it is our responsibility to, help solving them. This is a photograph that I have clicked in my OPD in the Nanath Mangeshkar Hospital. The horror story, if you hear, you will really feel very disheartened. This particular removable partial denture that you are seeing has been stuck in this patient's mouth for last 15 years with, a denture repair material, a self-cure acrylic, and it is there in the patient's mouth. And patient reported to us with excruciating pain. We literally had to cut that denture, section it, remove it and provide relief to him. And it was really a horrible sight to see the state of the underlying oral mucosa, which was completely necrotized. Why this happens? Why this patient must have gone to a quack? So socioeconomic issues of geriatric dentistry, financial problems, older individuals in low socioeconomic strata, where already there is a crunch of money, and then definitely dental treatment takes a backseat. Primary caregivers of dependent, disabled, or vulnerable relatives. See, there could be just one earning member in the entire family. That one person has to look after his wife, his children, plus take care of his elderly, ailing parents. So it becomes very, very difficult. The economic part of it is very difficult. So it is the burdening of the primary caregiver that happens. Increase in per capita cost of healthcare. We don't have to, I don't have to tell you this. You have all experienced this, and we are experiencing it more and more in the post-COVID era. Dependent, those elderly who are dependent on social or government healthcare system, because of the problem of population in our country, we are unable to provide, we are unable to cope up with providing the facilities, the right healthcare facilities to our elderly population, other patients also, but especially elderly population, and that's a bitter fact. So some medical and dental health issues of the geriatric patients which you must pay attention. Status of the public health and sanitation problems. These are, these are the general social problems, but they are not different. They are related to our field and ultimately related to the treatment that we provide to these patients. Existing diseases and medical problems, for example, diabetes, cancer, hypertension, neurological disorders, cardiac disorders, etc. Most of these patients, as I said earlier, have at least one chronic health problems, sometimes multiple. Increased burden on healthcare system. Diagnosed, undiagnosed, and misdiagnosed health problem. That is again a very disheartening fact that happens especially with elder individuals. We all love classifications. As an academician, even, I would like to classify the elderly patients who come to me. And amongst all the various classifications, again, if you, take Google Baba's help, you will have so many classifications available. But I find this particular classification very, very, very practically oriented. It is by Ettinger and Lyon. Functionally independent elderly, 70% of the population approximately, who are able to get to the dentist. Frail elderly, 14% of the total geriatric population. In them, the chronic conditions they cause the impaired mobility. So the mobility of the patient is hampered. Functionally dependent elderly, 5% of the entire population of geriatric patients. They are the patients who are homebound, who are bedridden, who are institutionalized. They cannot reach the dental clinic at all, not even with help. So these are the categories of the patients who are going to, whom we are going to see. I was about to say, who are going to come to us, but as I said, last 5%, they cannot reach us also. So these are the patients, and the treatment is going to vary according to which category does the patient belong to. So this is an example of functionally independent elderly. These are the people who are physically fit. They may be having systemic disorders, but that is controlled by the medications that they are taking. And they can, come to the dental clinic on their own, and they are in a relatively good state of health. So you can offer all kind of treatments, I would say judiciously, to these patients. Frail and functionally dependent elderly. Pune is a city which has maximum number of parents of NRI people. What does that mean? That means that the empty nesters, the children have gone abroad, and elderly uncle, auntie staying, they are by themselves. Sometimes they are, uncle is alone or auntie is living alone and the children are abroad. The question is, who will accompany them? Because you can see a very debilitated arthritic lady who has been accompanied by her husband, who has undergone a bypass surgery just 6 months ago. So the question is, who will accompany them for difficult treatments? And this happened. COVID happened. In these times, we had to literally go to people's houses because the elderly patients were suffering. I will say that we could not do all the treatments because sometimes the treatments are complicated and they have to be done in a dental clinic setup. But simple things like, mending a denture or relieving a denture, or, a clasp is broken, denture has to be repaired, or another denture, a simple case, another denture needs to be made. We were going to the patient. So for the homebound elderly, this is need of the changing time. We will have to extend our hand. We will have to go and reach out to them. Now, this is a big, big list. I'm going to scare you with the list, and you better get scared, because the geriatric patient who is going to come to you is going to have one or more of these disorders. Some common things like hypertension or constipation or, diabetes is listed here. But besides that, you will see there are so many problems, and some problems which are not seen, outwardly, like depression. The list does not end here. Parkinsonism, Alzheimer, as Rupesh pointed out, there was, Alzheimer Day yesterday. Why these days are celebrated? For the society to remember that these people are there, they are part of our society, and they need care. They need to be cared for. So the list of the disorders and diseases is long: osteoporosis, hearing loss, incontinence, falls. Let's, summarize this list. And what are the real, horrible evils? They are called as the giants of geriatric medicine. Multiple pathologies. You will see a patient when you poke history, you poke that patient, you poke out the history, you dig out the history. There would be diabetes. Okay, I'm taking a tablet for that. There is hypertension. Yes, I'm taking a tablet for that. There is hypercholesterolemia. Yes, I'm taking a tablet for that. So there could be multiple problems already existing in that elderly. And remember, I will remind you again of this sentence. If the elderly says that I don't have any problem, that means the patient is having some problem, but having a medication, and that's why things are normal. That means the underlying pathology is there, but the situation with the medicines, it is under control. Atypical presentation of a disease. Sometimes a disease which commonly seen signs and symptoms are there listed. Some other symptoms can be seen and that can be mistaken. The disease can be mistaken. Immobility, as I said, at this stage, again, I will request all the participants kindly mute mute yourself. Dr. Hasina, can you please mute yourself? Please mute yourself. Yes. So immobility, as I said, we cannot go to the patient. Sometimes, we are very busy. I don't have time. But remember, in future, this I'm talking especially to the young prosthodontists, our blooming prosthodontists, the PG students, the younger of the prosthodontic clinicians, staff members. Immobility is going to be the issue, and you will have to visit your patient going to their houses, to their nursing homes, wherever they are admitted, to their care homes, and you will have to provide treatment over there. So we have to think about all these things. I'm very glad I am having in this particular audience a lot of esteemed academicians also, and I sincerely want to urge them that please do something about this. Let us start with the specialty geriatric dentistry in India. Please, let's work for this. Instability falls. Fall is a culprit. A case later on that I'm going to share with you. The person just had a fall. He apparently was in a good state of health, but he just had a fall, doesn't remember what happens. So this is what happens with many, many patients. And fall is one of the deadliest giant of the geriatric medicine. Patients come to us because they suffer from trauma, sometimes facial, sometimes dental trauma, and we have to rehabilitate them. Incontinence. See, still the concept of diapers has not come to our population. Sometimes I feel that, people are sometimes unable to buy diapers to come for the treatment or to socialize. So incontinence is a big issue. The person has to visit the toilet many times. And sometimes when the control is not there, the person can wet himself or herself, and that becomes very, very embarrassing. Though we say that elderly people, it's a second childhood, but see, the elderly patient has lived his or her full life, and having such embarrassing situations is really heartbreaking for them. It's very embarrassing for them. Confusion, intellectual impairment, late presentation of disease. The disease already may be there, but the signs and symptoms arise later on. Silent presentation of disease. You just accidentally come across the disease, something, very common like anemia. There is no presentation. And the deadliest, the last one, polypharmacy. I'm going to deal with this in a much, elaborate manner, because we are the ones who keep on prescribing medicines without giving any thoughts what we should prescribe, what we should not prescribe. Or so many times, as I say, please take the trouble to cross-check with the patient's physician, whether you can prescribe this particular medication in spite of all the medicines that the patient is already taking. So polypharmacy is a very, very important thing to understand and remember. So let's talk about polypharmacy and potential harmful drugs in the elderly. So, let me draw your attention to Beer's criteria. Name is very, easy to remember for everyone. American Geriatric Society has come up with Beer's criteria. It is named after the geriatrician Mark Beers in 1991. What is the purpose? List of all the medications that a healthcare provider may refer to while prescribing medications to a geriatric patients. Because it's an American Geriatric Society, the criteria is for 65 years and above, but we should follow 60 years and above. We search Google for so many things. Today, after my presentation is over, I request everyone to see the extensive Beer's list that has been provided, and you will be shattered because some medicines out of them we so easily prescribe to the patients. The key points to remember over here, you can see the list later on. Key points to remember: to reduce the older adults' exposure to potentially inappropriate medications, PIMS as they are called, by improving the medication selection. To educate the clinician and patients about the medications. Because sometimes, as I said, the patients also don't give us the clear history. So what happens is we don't know what the patient is taking. So we need to educate the clinicians as well as the patients about the medications, the drug interactions, harmful effects of the medications, etc. And to serve as a tool for evaluating the quality of care, the cost, and the medications that are used in older adults. So polypharmacy, again, I'm saying, because I'm saying it 10 times, please remember, this is a very, very important aspect. Let's not assume anything. We are very good at labeling. We are very, good at, finding faults with people. Hey, elderly person, oh, what I'm trying to say something and that patient cannot hear anything. They are like that. I told this thing last time. How come you forgot? They can't think for themselves. It's very, very difficult to make sense to this particular patient. They are depressed and unproductive all the time. Patients are always depressed. Do not have these ageist assumptions. It's not always the case. All you need, again, as I said, my talk is more patient-centric. You have to have a touch of humanity for such patients. Do not ever label any geriatric patient, because you never know. The person who is sitting in the chair could be a retired district judge, or he could be a retired principal of a very reputed college, or maybe he could be a great scientist. So do not label. They have had their innings. It's just that they are facing some difficulties. Please help them. So age takes its toll, and there are a lot of tissue changes. Here comes the oral diagnosis, medicine, radiology, importance of that particular department. There are certain tissue changes and there are certain functional changes. We can see the tissue changes in teeth and periodontium, that is the bone, periodontal ligament, as well as oral mucous membrane, gingiva, etc. And there are some functional changes like salivary flow, the quantity and quality, the taste sensation gets hampered sometimes, deglutition becomes difficult, mastication becomes hampered because of the lack, partial lack or complete lack of teeth. Let's understand one by one. Okay, so let me come up with a list of common health issues in the elderly. The dental caries, dry mouth, that is xerostomia, we face as prosthodontists, we face it so many times. Missing teeth because of the masticatory inefficiency, periodontal problems that you see, loss of the supporting structure or disease of the supporting structure, attrition and abrasion of teeth, loss of or alteration of taste sensation, recurrent mucositis, and our enemy, RRR, residual ridge resorption. So we can divide the problems that we are facing in the elderly, the problems related with the teeth per se, and the problems related with the supporting structure. The oral health issues in elderly, as again, I'm talking as a prosthodontist to you now, the loss of multiple teeth causing aesthetic and functional problems comes first. That's why the patient comes to us, okay? In my setting, like a hospital setting, what happens is sometimes the gastroenterologist refers the patient because the patient is suffering from irritable bowel syndrome, okay? Recurrent episodes of diarrhea, nausea, hyperacidity, constipation, and the patient is really in a very difficult stage. So that's why, besides aesthetics or phonetics or other things, the patient is referred to me because the patient has to chew the food properly in order to get rid of the irritable bowel syndrome. Then the poor health status of remaining teeth, as we call it DMFT index, increased requirement of dental treatment. As the age advances, the teeth also slowly start deteriorating and the supporting structure also starts giving way. Degenerative changes in oral and perioral tissues, that is the muscles, the perioral and facial muscles, muscles of mastication, muscles of facial expression, and the oral mucosa. There are degenerative changes seen there as well. Migration, we all see that. You lose one tooth and the entire harmony comes to an end, okay? You have the particular theory of forces of theory of equilibration of forces. So when this particular tooth is gone, this tooth, and this tooth start encroaching in this particular space, and then the entire harmony of the occlusion is lost in this process. Most important thing, temporomandibular joint disorders. I have had a discussion once with Dr. I don't remember his name from our hospital. Yes, Dr. Jaydev Panchavag, who is a neurosurgeon. And, he told me that, are you very, very sure whether the temporomandibular joint problems are definitely associated with the loss of teeth? I said, I don't know, but many patients who come to me, they come with, complaint of pain in the temporomandibular joint region or clicking or crepitus. And once you give them good prosthesis, once you rehabilitate their occlusion, the problem gets corrected. As I said, I'm not stating any theories here. This is sheerly my own practical experience. I may be wrong, but I want to share this with you. So this particular old lady, 81 years, and she came to me not only because her dentures were loose and they were uncomfortable for wearing and chewing. One particularly, common thing that I see in all these patients, not that all of them are not affording, but perhaps they don't know that dentures need to be changed. All these patients these people have been wearing their dentures for some 15 years, 20 years, and I really, feel aghast about it. How this can happen? So this particular lady also had loose dentures. They were uncomfortable. The denture teeth were completely worn out, and she could not chew her food properly. But her main complaint was the pain that she had in her temporomandibular joint. So what I could see in this particular case was severe maxillary and mandibular residual ridge resorption. The dentures were ill-fitting, worn out teeth, faulty occlusal contacts, and every time the patient tried chewing with the dentures, the pain aggravated. All I did was just conventional complete dentures, the right kind of dentures for this particular patient. And the result that I got was gradual reduction and subsequent relief from the temporomandibular joint pain. And happy patient, and even I was happy that I could relieve her from pain. See, here again, the requirement is necessarily not aesthetic every time. It could be something else, something more important. So the tooth loss, which is a modifier of normal physiology, edentulism, that is the loss of teeth, it was found to have a significant effect on residual resorption, jawbone loss, because, it's cause and effect kind of a thing. The teeth are lost, so the supporting residual ridge starts resorbing. Okay, the reduction affects the face height and facial appearance, which are altered following the total tooth loss. And then the typical protrusion of the mandible and the lip and chin, giving an aged look, like, this kind of aged look that makes the patient also feel more aged in heart. We were just discussing before this particular talk that, we have to, how to keep yourself young. So you have to be young at heart. You have to be happy. When the patient is not happy, the patient is feeling disabled, debilitated, then that, urge for life is slowly gone. It gets diminished. Tooth loss leads to impaired mastication. As I said, as a hospital dentist, this is very important thing for me. Impaired chewing efficiency and performance. Thickness of masseter muscle decreases in edentulous patients, thus decreasing the bite force. This could reduce the desire to bite, to chew, to swallow, and this could lead to wrong food choice, that is the soft food choice full of carbs. A patient told me, "Doctor, these days I get fed up of eating." I said, "What are you talking?" He said, "Yes, it is so difficult to chew. It is so difficult to eat food that I'm really tired of eating. I have stopped, instead of 4 meals, I'm somehow managing to have 2 small meals." And it was showing on the patient because patient had lost a lot of weight. Patient was very, very, the weight loss was showing on the patient. He was very thin. And soft food choices, because they cannot eat properly, they will always have soft, overcooked food. Mostly it will be carbohydrates that may lead to diabetes mellitus, or if there is existing diabetes, then that can get aggravated because of the soft food choices. And this negative impact on diet and food selection ultimately takes toll on the patient's health. So loss of the teeth also results in impaired support to the orofacial musculature. Loss of the teeth may induce oral dyskinesia. What is that? It is abnormal, involuntary, patterned or stereotyped purposeless orofacial movements. You must have seen many old patients who are all the time, because of the lack of the teeth, the movements are happening and they cannot help it. So that's called as oral dyskinesia. And this particular case I will discuss once more later also. Suppose you want to, improve the tone of the muscles. See, if you want to build your muscles, you go to the gym. The younger generation understands that. So for these patients, what we could do is we can teach them some easy exercises. I would call them oral or facial physiotherapy that will improve to, their facial muscle tone. Let's just take a look at this one.
Santosh, puff both
Can
your cheek.
listen to the audio?
Release.
Okay.
Yes, ma'am. Yes.
Yes, yes. It's
Puff
audible.
left cheek.
Good.
Puff your right cheek. Try and pucker your lips. Draw them over the dentures. Puff your lips. That is little tough. Puff your lips. Blow air slowly.
Some simple exercises like that. Some, if the patient repeats them at least thrice a day, they really bring about remarkable change in patients' facial musculature and muscle tone. So loss of teeth also causes impaired mastication. This is the case that I was talking about. This lady came to me, she was referred to me by gastroenterologist for, irritable bowel syndrome because she could not chew her food properly. It was affecting her health. Impaired masticatory efficiency and performance. Thickness of masseter muscle decreases in edentulous patients, decreasing the masticatory force. Reduced desire to bite, to chew, and to swallow food, and negative impact on the diet and food selection, soft food choices, leading to systemic disorder. You must have noted that I'm saying it again. That means this is a point which is very important to be remembered. So she had complaints of flatulence, irregular bowel movements, indigestion, and ill-fitting dentures caused all this problem because she could not chew her food properly. And the treatment? Simple. Conventional complete dentures. This particular video is in Marathi. So, when she is talking, I would just, before this starts, those people who can understand it's good. Otherwise, all she has to say is she used to have a lot of gases, that is flatulence. And, her bowel movements were also very, very irregular. And after correction in her dentures, the new dentures, she could chew and eat her food properly. And that gave her a lot of relief. So let's listen to her.
काकू, तुम्हाला कवळी लावून पचन संस्थेचा काय फायदा झाला?
मला कवळी लावून पचन संस्थेचा फायदा बऱ्यापैकी वाटतोय, कारण मला पूर्वी गॅसेस वगैरे व्हायचे ते कमी प्रमाणात आहे आणि टॉयलेटला सुद्धा व्यवस्थित होते, कसलाही प्रॉब्लेम नाही.
काकू,
So at this particular juncture, I would like to ask how much time do I have? Dr. Shyam Mohan?
It's good, fine.
Should I? Yeah, please warn me, because why I'm asking here is, this is a kind of a one part completed and I'm moving to the other part. So yeah, okay, good. Let me.
Interested.
Yeah, okay, fine. Thank you. So treating a geriatric patient, are you treating a geriatric patient? Let's, take into consideration some important points. A thorough medical, social, and dental history of the patient with the help of accompanying relative and friend. I will say this word, accompanying relative or friend, 10 times today. That means it's very important. The geriatric patients come to you, they give you history. But, sometimes when you say that somebody has to accompany you, sir, or, auntie, somebody needs to come with you, person gets irritated. Why? I can't come on my own or what? I'm okay. I'm perfectly all right. I don't need anybody. No. At least in my OPD and in my clinic, I follow this very, very particularly. Of course, after experiencing some really, where my heart was about to stop, such kind of experiences, that a near and dear one, a relative or a friend or anybody, a responsible adult has to be there with such people. You should contact patient's physician for getting to know the known allergies or ongoing treatment, if any. Remember polypharmacy? Remember the Beer's list that we talked about? Recent medical and dental reports. When I say recent, I mean it. Done within the last 2 months. The blood tests, X-rays, or any other test. Sometimes you see all those historical papers, So, old OPGs and old X-rays and old blood tests and all that. You gently tell the patient that this is fine for the reference, but I would want the recent reports. Check the ongoing medicines. Have I said it already 50 times, Dr. Shyam Mohan, sir?
Yes.
So ongoing medications, please, before writing your prescription, make sure that you are not making a blunder of polypharmacy and you are not pushing the patient into any severe drug interaction. So this is a very, very important point. When you talk to the patient, I always tell whoever takes my advice, how do I begin the treatment? I always tell them, never begin the treatment at the first appointment. Get to know your patient, get to know your patient's medical history, get to know your patient's social dental history thoroughly, all the medical records, all the medications, everything. Just speak to the patient, make the patient comfortable. That is all you will do in the first appointment. Never be in a hurry. Take an informed consent. This particular thing, many, many times it is neglected. For all the youngsters over here, I'm not overrating this. This is very serious and very important. Taking an informed consent in the language comprehended by the patient and relative. A patient who speaks only, say, Malayalam, or the patient who speaks only Marathi, and I give a nice consent form which is written in English, and the patient is unable to follow. The patient can scribble some initials in English. That does not mean that the patient comprehends the language. So understand, medico-legally, it is very important that the consent has to be taken in the language comprehended by the patient and the relative. The consent has to be duly signed. In our country, sometimes we come across with patients who cannot read or write. A thumb impression of the patient, in case the patient is debilitated or illiterate, and the thumb impression or signature by the patient, and also it should be signed by the primary care giver prior to commencing any treatment. No shortcuts here. As I said, do not start anything at the first appointment except for this thorough case history, medical records, dental records, and informed consent. Spend some time on that. That is an investment for your own secured future. Talk to the patient and the primary caregiver about the chief orodental problem, as well as the other problems and ailments that the patient is suffering from. Make a list of it, make a note of it. Insist on having a responsible accompanying person. I'm saying it 15th time. Primary caregiver, close relative or family friend for every appointment. It's just not that for that one appointment somebody shows up. And then for important appointments like, say, you have to insert an implant, or you have to, take a final impression or something like that, where the relative is not there. Suddenly patient feels tired, patient feels fatigued. And the case that shook me up in my life, my patient collapsed in my chair. I didn't know what to do. All that, CPR training that I had taken, I was just perspiring. I got scared. Thankfully, I was in the hospital setting. I immediately got treatment for the patient. But what would I do? That's why, I could arrange all the treatment for the patient. But what was missing that patient did not have anybody accompanying him, and I had to sit by the patient till such a time that the patient recovered. Not only that, I dropped the patient home that evening. So morning 9 o'clock, I started working on that patient. He collapsed. And then 5 o'clock in the evening, I dropped him home personally because there was nobody with him. So please, you don't have to learn lessons. You can learn from the experiences of somebody else. I'm frankly sharing my experiences with you. So insist on having a responsible accompanying person for every appointment for the necessary information. Sometimes, patients forget to give a particular history, and the relative or the primary caregiver will say that, Papa, but you also are taking medicines. You are also taking low dose aspirin, isn't it? So somebody will, remind that patient. Or easy conversation. Sometimes, rather than having just one-to-one conversation, it is always better to have somebody else also who is reassuring to the patient. That is important. And in case of any dental and medical emergency, you will manage the emergency, but you will need somebody to, sometimes give consent for some major thing, or sometimes just be with the patient, inform the people at home, etc. The 3 Ds of geriatric patients: depression, delirium, and dementia. Sometimes they present themselves singly, sometimes it's all intertwined. It can also be noted during conversation with the patient. Again, the point, do not start treatment. Just talk to the patient, gather information. And with the conversation with the patient and inputs given by the accompanying persons, identify the altered behavior and note the clinical change in physical, physiological, or psychological status in the geriatric patient during the consultation, during history taking, during general and oral examination. Sometimes patients are lonely. As I said, in the city of, patients who are parents of NRIs, they are lonely. They don't have attention from anybody. Sometimes it happens in families also. The elderly person feels very lonely. Nobody has time to pay attention to his problems, or, nobody even has time to converse. A casual conversation also is not possible. So it could lead the patient to exaggerate the symptoms or to make repetitive complaints of a non-existing cause. Sometimes they just want to, they just want somebody to talk to them, somebody to listen to them. Try and identify the underlying psychological or emotional issue and speak to them about it gently, but be firm about it. Patients repeatedly coming for denture adjustment. When you are sure in your mind that there is no problem with the underlying mucosa, there is no problem with the denture, gently ask the patient and gently convey to the patient also that there is no problem, but feel free to come for a checkup whenever you want to come. That is your social responsibility, not only as a doctor, but as a responsible citizen. Okay. So if necessary, sometimes you have to suggest and sometimes you have to insist. Over here, again, the accompanying person is important. Psychological counseling and psychiatric opinion becomes very important. And sometimes you have to insist, or sometimes you have to put your foot down that unless you have that, you will not proceed with the treatment. Treating a geriatric patient, then be sympathetic and listen to the patient's complaints patiently. You have to develop a lot of patience to be a geriatric dentist. Make sure that the patient has grasped your questions. Sometimes they have hearing loss, or sometimes they are confused and they don't understand what you exactly have asked. Repeat the question if necessary and make sure that you are clearly audible to the patient. In case of hearing deficiency, sometimes it helps to write down in a clear and legible handwriting, or nowadays you have computer, so a printout in large font size, your clinical findings, advice, treatment plan, and hand it over to the patient and relative so that the patient can again go home, read the treatment plan and whatever you have said again. And then if the patient has any questions, the patient can come back to you. Again, over here, patient's writing is very important. Always tell the patient Write down all the complaints for the primary consultation. Uncle, auntie, why are you coming to me? Please write down whatever problems you have on this piece of paper. And also for the subsequent follow-up visits, this is very, very essential to write down all the problems, because as I said, sometimes they forget, sometimes a point is missed. That's why writing down all the questions is very important for the patient. It makes identification of the problems easy and troubleshooting very, very satisfactory. This is a very important thing that we all must remember. Schedule the geriatric patients as far as possible during morning session. After they finish their morning rituals, their breakfast, their medication, whatever, and they are comfortable, they are at ease. The geriatric patients are mentally and physically fresh during morning hours after a restful sleep. Of course, as I said, no rule applies to the human beings, to the human body. So there could be exceptions, but in my practice, I have always found that they are more cheerful, more cooperative, okay, during the morning hours after they finish everything and they are fresh. Avoid late evening appointments, as most of the geriatric patients feel little low. It's lowering of the physical and mental energy levels in the evening, which is also called as sundowning effect. And sometimes they get confused when the light is little dim. Sometimes going home also becomes difficult for them. So it's all in all, it's always better to avoid this sundowning effect and call them in the morning session. Avoid long appointments. I need not say, to the prosthodontists, we all know that we handle our patients minimum 30 minutes, maximum sometimes to an hour or so. But does this elderly child of yours has that much stamina to live through that entire session? You are doing your work, you are engrossed in your work, but you have forgotten that your patient is tired. The muscle fatigue sets in early in elderly patients, so you have to be very, very careful. If long duration is unavoidable, then what you can do is you can give them a toilet break. You can give them a tea, coffee, snack interval during a lengthy appointment. Let them just sit, let them just relax. Mind you, the treatment will be much more easier than, just pushing the tired patient and just saying that, just some more time, uncle, just some more time, auntie. That does not really help. Give them a break, understand their need. You are a geriatric dentist, you are different. You are not just a prosthodontist, you are a geriatric prosthodontist. So some more requirements, the list is endless. The dental operatory should be very well lit. Forget about all those fancy dim lights and all that. No, it has to be well lit, well ventilated. The air is very important. The ventilation is very important. And geriatric friendly interior design, which includes a toilet with a railing. Sometimes, operatory pathways that are clear, no marble, no over polished tiles, non-skid kind of flooring is essential. The pathways have to be clear. They have to find their way easily. Provide sufficient railings for them to hold on to the railings and come inside the dental operatory. And there should be no clutter in the operatory. Be gentle and smile often. Smile is very, very reassuring for patients. Encourage your assistant staff also. You train them to be polite and to be sympathetic. Thankfully, we are from the Indian society and we have been, right from our upbringing is such that you are always told, you are always, taught to respect the elders. But sometimes the assistant staff could be a little rough with them and that puts the patient off. Okay. So train them properly how to handle these little different patient of yours. A comfortable atmosphere always makes the treatment go easy. If they're comfortable, they will be cooperative. It's as simple as that. So now we come to all the treatment aspects of the geriatric patients. And now again, I will ask my friend, Dr. Shyam Mohan sir, how much time do we have, or we have already run out of the time? Please feel free because I tend to go on. I told you very honestly.
How about 10 more minutes?
Yeah, that should be fine. That should be fine.
Less?
Yeah, absolutely. 10 minutes should be okay. No problem. Yeah. Okay. We will go little quickly so that we will have some time for question answers if required. Okay. So I will just brush up little quickly because I think the most important part of the presentation was this that I have talked right now. The, unaddressed aspect of it. Prosthodontic, everybody is a boss. And, the postgraduate students are also these days, I see them all very confident. So I have no doubt about the prosthodontic skills. How to handle differently, let's learn that. So we can, as I said, geriatric prosthodontics doesn't come separately like that. It is geriatric care, geriatric oral health care in totality. So preventive care, oral surgical treatment, restorative treatment, endodontic treatment, prosthodontic treatment, and most important thing, after everything is done, oral hygiene maintenance. And in our case, prosthesis hygiene maintenance is everything that comes under the umbrella of geriatric oral health care. So prevention of oral diseases, because in our country, like a third world country, where resources are limited for the geriatric patients, prevention is best. Prevention is better than cure. We have all learned it. It's time that we practice it and we remind gently our elderly patients that prevent the disease from happening. Be little particular about your oral health. So teach them, hold their hand, teach them how to brush their teeth, teach them how to clean their prosthesis. If, interdental hygiene, they don't know how to do it. Teach them how to floss. Dr.
I
Anu?
request everyone to mute their microphones, please. Those who have not muted, kindly mute your mic.
Yeah, Dr. Baiju, Dr. Anu, I will please, can I request you to close your mic, please? Thank you. So if the patient is unable to hold the floss, that can happen. You provide them with easier facilities, but you train them. You just don't say that, okay, you brush your teeth. Okay, you keep your denture clean. Nothing happens because of that. Now, about mouth rinses, everybody, all the patients and their relatives, sometimes some well-to-do patients, tend to ask me, how if I use mouthwash? I tell them there is a cheapest mouthwash available if you want to use it. Which one? Water. The water which you use every day. Again, in the Indian culture, we have this concept of rinsing of the mouth. Okay, we are very particular. It's called as Danta Dhavan in Sanskrit.
Excuse me, participants kindly mute.
Thank you. So rinsing the mouth often, because you will brush your teeth twice, you cannot overdo it. Sometimes your geriatric patient needs assistance for brushing teeth and cleaning the prosthesis also. So rinsing mouth, drinking enough water is something which will, take the prevention in a long way. Okay. So this is very, very beneficial. Please explain the importance of drinking water and rinsing mouth to your geriatric patient. Educate your geriatric patient. Again, as I said, this is very important. And the accompanying person. When you educate the accompanying person as well, the primary healthcare giver can go back and educate the family. Okay. The relative, friend, caretaker, whoever it is, about the preventive dental care and existing treatment needs. Somewhere, you are touching that aspect of community dentistry also, and you are doing your duty as a public health caregiver. Promote good oral hygiene habits. Gently point out if the patient is having any vices, please point out. Please tell them how much harm they can do. And if the patient is not brushing or not doing something, for example, once I asked the patient, but why won't you brush? The patient said, no, my teeth hurt. He had never expressed it before. So everybody at home kept on screaming at him that he does not use his brush, but nobody understood it was hypersensitivity. The dentine was exposed. So, promote good oral hygiene, at the same time, understand their problems if they are facing any for these hygiene practices. Motivate to practice oral hygiene maintenance and effective follow-up recall appointments. From my hospital OPD and from my clinic also, we regularly make phone calls to these patients. Every 3 monthly, the patient or the relative is gently reminded to come for an oral health checkup also. And in COVID times, we have gone to their houses. If they had a little problem, even if, some patients had said, doctor, can you just come to see whether everything is all right? If something goes wrong, I won't be able to get treatment in COVID times. We have done that as well. Please do that. It's your duty. So in a very simple language, this was a very nice slide that I found on the internet. Simple language. Use simple language for the patient. When would you need to see me again? If you have bad breath, if you have loose teeth, you have stained teeth, you haven't had your cleaning done, you have to do it every year. If you have not done it past year, you need to come to me. Any kind of pain. Indian patients are very patient about everything. Pain, they take pride that, okay, I could bear the pain easily. What to do? I did not take any medication. The pain is there since last 3 months. Well, explain them bearing pain is not correct. You have to come to the doctor for that. Any discomfort, any irritation, any ulceration, right from ulceration, that is, the stress ulcers, we call them, oral ulcerations, stress ulcers to any pre-malignant lesion. It could be anything. So never to neglect that. And loose dentures, because we are again prosthodontists. When the patient asks, when do I make my new dentures? I always tell them that come for an examination every year. We may need to reline or rebase your denture, or some years after that, maybe after 3 years, 5 years, it differs from patient to patient. Requirement is different. We may have to change your dentures. So it is not Hero Honda, fill it, forget it. You have to change your dentures. And whatever patients I have been seeing, very elderly patients from all socioeconomic strata, somehow they are all wearing their dentures for last 15 to 20 years. I don't know whose mistake is that. Is it the patient's mistake, or it's the dentist who never told the patient that the dentures need to be changed regularly? Let's introspect. Now, my mantra. As I said, my lecture is not full of glamour. It's not full of any glitter. It's simple. And yes, the patients who come to me, the patients who I see, the class 2 or class 3 kind of Ettinger's classification patients, I have one mantra to give all the young prosthodontists. To your elderly patients, if they are hale and hearty, if you're okay, you can perform any kind of treatment on them, provided their health permits. Otherwise, keep it simple and keep it case-based. There are no rules. Again, I'm saying it for the second time. There are no rules. So let your treatment be case-based. It may be different from patient to patient. 2 complete denture patients also you need to handle differently. So keep it simple. So what are the challenges and problems our way? Inability of the patients to attend long and frequent appointments. We talked about it. Low tolerance for pain and discomfort during treatment. The mucosa is fragile. The teeth are mutilated. The patient, is elderly, so cannot withstand. So think about this as well. Residual ridge resorption, short dental arches, atresion, abrasion, erosion, brittleness of teeth, financial constraints. These are all the factors which we have to take in consideration after we diagnose what to do. We have to think about this and then make a suitable treatment plan. Suitable not to you as a clinician, but more importantly to the patient as a geriatric patient. So conventional complete dentures, my favorite. I absolutely love conventional complete dentures. And most of the times they work wonderfully well. And the patient is also happy because it's a relatively simple, uncomplicated treatment. So the same patient whom I was teaching the facial musculature exercises, he was a very high profile person running an industry. And somehow he was very concerned about his toothless look and sagging facial muscles. Imagine, he was also wearing his dentures for 15 years. He couldn't afford it. Very well, he could have afforded anything. But he said, Madam, I didn't know. Otherwise, I would have got my dentures made long ago. So see, lack of public health education comes there. Treatment, simple, conventional, complete denture. And after the the oral musculature physiotherapy, facial musculature physiotherapy, the patient is happy with his dentures and can perform his speech, his day-to-day thing, because he is a very high profile kind of a person. He's happy with his denture and the toothless look is gone. Another patient who came to me, I'm queen of gag reflexes, all the gag reflex patients, I think, severe gag reflex patients, they all come to me. Again, the trick is tender, loving care. This is again a difficult child. You have to treat the patient like that. I could not insert even the mirrors in this patient's mouth, leave aside the cheek retractor because the patient would easily gag. But from that stage, where she cried in her first appointment when, she said that I cannot put anything in the mouth easily, I feel very nauseated, she started wearing it very easily. So we just see this.
स्मिता ताई, तुम्हाला गॅग
Her
रिफ्लेक्स
name is
आहे.
also Smita, by the way.
तर गॅग रिफ्लेक्स असताना सुद्धा तुम्ही डेंचर्स कशी काय घालू शकलात?
Now she is
कशी
wearing the
सुरुवात
dentures
केली?
very, very easily.
सुरुवातीला 1-2 महिन्यापूर्वी मी जेव्हा माप द्यायला आले तेव्हा ते अक्षरशः म्हणजे काहीच मला 1 सेकंद पण ठेवता येत नव्हतं.
She could not put the dentures in for a second also, she said.
डॉक्टरांनी मला हे केलं, प्रोत्साहित केलं आणि त्याला वेळ लागला, अर्थात 1-2 सिटिंग करायला लागले. त्याच्यानंतर
I'll just skip this because it will take some
स्मिता
time.
ताई,
Another case, as I said, most horrible thing to happen is fall. This particular patient, you will see that the teeth have been fractured at CEJ. He had a fall, and to this date, he does not remember how he fell, why he fell, just doesn't remember. But it was a big social, psychological trauma for him because he wanted to look normal. He wanted to speak normally. And the simple thing, immediate or provisional prosthesis for the patient was given to him, and that rehabilitated not only dentally, but mentally also. The patient was very, very happy. Simple claspless comfort of flexible partial denture sometimes helps. This particular patient that I have treated for oroentral fistula, okay, fortunately, she had one robust, strong distal most molar present over there. So I could treat her very simply with a removable partial denture. This particular patient goes every Thursday for her dialysis. And every Thursday she used to come to me for treatment and then bravely go for her dialysis. Imagine the plight of the patients and how they face their life. Cast partial dentures. I love cast partial dentures. I think they are the best. What do you say, Dr. Shamohan sir?
Definitely.
Yeah. Again, some patients, because it's a hospital setting, some simple maxillofacial prosthesis, which was my initial passion. And that's how I came across with Dr. Manju. There we met at Tata Memorial Hospital. So some simple cases like this, mucormycosis. We face a lot of such patients after COVID, that dreadful, COVID wave, and lot of mucormycosis post-excision patients used to come. And what we provided them, they wanted to eat, they wanted to have some nourishment somehow. The simplest thing we could do is a very, very simple provisional obturator. They could swallow their food, they were happy, they were well nourished with that food, and later on it could be replaced with a permanent kind of obturator prosthesis with teeth. Guide plane prosthesis. I don't know what your experience is, Dr. Sham and Dr. Manju, but the surgeons always refer for the correction of the deviation long time after the patient undergoes the surgery, and we are just helpless. But in this particular elderly patient, I could help him with some exercise kind of a device, some guide plane prosthesis, and he did it also very, very religiously. I'm just winding up now. Word of care over here. Please respect the aging and or compromised natural tooth structure and supporting periodontium. Please avoid any heroic things. That's what I would advise over here for implantology as well as for FPD. This particular case, fulminating oral candidiosis patient reported to me already implants were put. My good friend, Dr. Paresh Gandhi, he diagnosed this particular patient and we had a discussion on this case. And he had severe diabetes, the HbA1c level, something like 12.9 or something like that. He had some pancreatic issues. He had some thyroid problems. Everything was there, but the implants were still placed. Why? This is not correct. According to me, at least, this is not correct. So when you are going to place implant in an elderly patient, ask, have you checked the medical history thoroughly? Systemic disorders, vitamin deficiencies, ongoing medications. I'm saying it 50th time. The Beers list, anti-resorptive drugs, bisphosphonates, estrogen receptor modulators, denosumab, HRT, that is hormonal replacement therapy, and calcitonin, though these days it is found little questionable. Anti-COVID drugs, more important thing, radiation therapy, all this thorough history has to be asked. Otherwise, this is what happens to the patient, and this is not done. This is not right dentistry, and I don't even call it glamorous. So let's work together. Why? Because we always look at the DVAN principle, isn't it? We want to have complete rehabilitation, functional, social, psychological well-being. So we have to be in this together, not only prosthodontists, as I said, all the specialties, we have to be in this together, understand each other, and provide the right treatment for all these, elder children of ours. These are all my uncles and aunties who are well in their 80s and living a nice and full life. So thank you very much. And, I'm so happy presenting this particular, knowledge sharing with all my friends in God's own country, Dr. Shyam Mohan, Dr. Manju, Dr. Rupesh, Dr. George John. And let's hope that we meet in Kochi sometime. Rupesh, we have a deal?
Absolutely, absolutely. The deal is on.
Thank you very much. Thank you. I'll stop sharing the screen.
Absolutely.
Excellent presentation, Dr. Smita. As usual, I've attended many of your talks. The last time symposium too in Delhi,
Thank you, sir.
Kamal Shigli, the team is really good with geriatric dentistry. And I would like to reiterate, she is one of the most leading geriatric prosthodontics in India now. So don't lose this opportunity. The podium is open. I cannot see any questions posted in the chat box. So you can all come up with your queries. So we have an authority here. Smita, I got one small thing.
Yeah. Yes, sir.
While the kids are raking their brains.
Maybe, they are hungry now. It's 9 o'clock, no?
We have few questions along with
sure. Please, shoot. No problem.
They should be hungry for more knowledge.
Ideally, yes.
Can we ask those questions? Actually, we had few questions in that Google form you got, no? I have sent to you, no?
Yeah.
So one thing I want to ask about this 60. You said that in everyone above 60, we would like to treat as geriatric. Don't you think that if the physiology is much younger, should we treat even if does the chronology matter, or is it the physiology?
No, as I said, sir, if the patient, there is no rule over here. As I said, keep it simple. I also said that keep it case-based.
Yes.
So if the patient is otherwise healthy, there was one patient who insisted on implants. That patient was 86-year-old. But this thing was done with all due care. We did it in the operation theater. But he had 2 mandibular implants because the patient used to walk 10 kilometers every day. He was absolutely hale and hearty. So rule of 60, meaning 60 onwards, we start being careful. Sometimes the patient may outwardly seem to be healthy, but maybe having some problems. As I said, some silent disease somewhere, or some problems. So we deal with care. There is no contraindication. We just have to exercise some care. That's all.
Okay, good.
I think, Shyam, to add to what you are, it's the same thing. I think I had a similar kind of a query, because many times, and a younger patient, chronologically younger patient, may be psychologically older. I think that's what probably Sam was trying
Yes,
to,
very true.
because yeah. So chronology, the years doesn't matter, is what Sam was trying to say. Does the year matter?
Definitely.
Because sometimes these youngsters, they behave like youngish, 40, 45. They act like they are kind of frail and
Yes.
yeah.
Yeah,
Whereas
especially,
you
Rupesh, this change I found post-COVID, lot of depression and lot of, the scare that something is wrong came up in the younger individuals also. And to the other side, not just psychological, just 8 days ago, one of my close friends, he's also a dental specialist, he underwent bypass surgery at age of 52. So this is something, as I said, thoroughly examining the patient and taking a thorough history and sometimes subject the patient to tests is very essential.
Yes, very true. And the same thing holds true to Kerala too. You were commenting about the NRI state, how the elderly are abandoned. The same thing in Kerala too. You get mansions here with only the elderly couple living there. And we too get patients not accompanied by the kids because they're all either working or studying outside.
Correct. Correct. That's why Dr. George shared that photograph with me, the billboard. He said that, this is what is happening, in Kochi. And I'm very sure this must be the case everywhere in the country now slowly.
Exactly. And the BS list was awesome. I would really recommend postgraduates to, look deeper into the BS list. Please take a note of that. And your emphasis on conventional complete dentures, Smita, that is a very important point. I think that has been neglected in the UG curriculum too, I would say. When they come for post-graduation, actually complete denture knowledge is almost nil nowadays, because it is all into implants and fashion dentistry, as you rightly put. So that emphasis on complete dentures, it is very important. Conventional dentures, we should know, we should be training them. In emphasis should be brought back in undergraduation, I feel, regarding complete dentures. Your take on that?
Absolutely, sir. We should be, I think, meaning, am I sounding very orthodox when I'm saying that we have to be back to our basics? Where are the basics gone?
Exactly.
Where are the conventional dentures? Where are the nicely made cast partial dentures which make the patient comfortable?
True.
And where implant is possible, I would say 100%. Why not? It is, a treatment modality if a patient can afford, and if the patient's physical and oral condition permits, by all means, go ahead. But think about the debilitated patients whom I face day in and day out, or whom we go and treat in the elder care homes. What do we do for them? Should we refuse treatment to them?
Yes.
Shouldn't we be doing conventional dentures? Shouldn't we be giving them removable partial dentures? We should be doing that. Exactly. I think, we should climb higher, but we should not forget our basics. Exactly. We should not forget our foundation. That's what I feel.
I'm actually in the soft rich cases also. No, usually
absolutely
without implants, it's very difficult, no? But for you, I think that again, it's a challenge, no? Many patients for placing the implants. Then
basically what happens, as I said, that, luckily in our hospital, we have all specialists working together. So even for a difficult case, we all come together. Suppose a tissue excision is required, or suppose some bone augmentation is required. We feel free with each other to take each other's consultation, discuss and design an optimum treatment plan for the patient. So it is not a single mind which is working here. The credit is not just mine, it is everybody.
But I'm asking, see, without implants, will it work, ma'am?
It works. As I showed you, whatever cases I showed you, and one photograph that I showed you, we have these impression techniques, modified impression techniques that we can have, occlusal schemes that we can give. Again, as I said, we are entering into a different topic altogether. Management of poor foundation. We can manage it. It's not difficult. Meaning with implants, things have become easy. Those who can get them done, fine. But for the patient, like I showed you the case of a patient who is physically compromised and still went ahead with implants, then who is the culprit? So it's not that you cannot do implants. You should. Whatever you know the best, you should do for the patient, provided it is really best for the patient. That's what I mean. And we can manage complete dentures. There's no problem. All these patients are eating well. That's why I put those clippings. to
Yes.
show that you can overcome irritable bowel syndrome with conventional complete dentures. Why not?
I think with proper occlusion, then about the neutral
Absolutely.
concept, everything we have to consider. No?
Absolutely.
We have the very eminent Dr. Manu Rati with us. Dr.
Yeah.
Manu, some inputs from your side?
Thank you so much, sir. Compliments to Dr. Smita ma'am for the wonderful presentation. And here, before I put my comments, I would like to extend my thanks to Professor Sudeep, sir, the president of the IPS Kerala branch. Thank you for this hand-holding with the Board of Geriatric Dentistry. Thank you so much, sir. And thank you so much, Professor Manju ma'am, for arranging this wonderful webinar. And it is really a enjoyable webinar on this weekend. Really enjoyed my Friday evening, really. And Shyam sir, Professor Shyam sir, it is, I really cherish my association of almost 2 decades long with you. And I am just fan of your knowledge. So regarding that lecture, what she said that regarding one query was being discussed is regarding the implantology in the geriatrics, because as far as the scientific evidence is related, there is hardly any evidence which can give us SOP or standardized procedures for geriatric implantology. Hardly any. So we are in the stage of developing that evidence. So it is all currently a practical experience and not much of the scientific support in favor of that. And Madam said that contemporary, yes, contemporary more or less so. And main concern is there are not established back-off strategies for dental implantology in the geriatric patients. That is one concern. Because if the implant is given at the age of geriatric 60 or 65, what happens at 90 or 100? Those there are no established backup strategies or established protocols for that age group. So we have yet to develop as a professionals, specifically in the area of geriatric implantology. Till we have that evidence, we, I think, can survive with the contemporary approach, as Madam said.
Yes, that's it.
Thank you.
Students, I appeal again. I think one Dr. Shruti Sara Varghese has a question. You can unmute and ask Dr. Shruti.
Do we have any question in YouTube?
Yeah, from Dr.
So the same question which ma'am asked, the success of implant in geriatric patients.
So that's what I said. Me and Dr. Manurati madam already discussed this. And as I said, it opens a Pandora's chest. I mean, this is a topic by itself. And I was discussing with Dr. Manju that there are various topics in geriatric dentistry. So, if you people are enthusiastic enough, we could have a lecture series with various experts like, geriatric implantology, somebody else will discuss. Somebody else will discuss geriatric periodontology. So, the field is really vast. So we will keep that for the next subsequent lecture. What do you say, Dr. Manju?
Yes, ma'am. We'll arrange an offline program.
Yes.
Good. We'll be happy.
Yeah.
Is the delegate asked this question. There are few studies regarding the geriatric implantology. As far as geriatric periodontology is concerned, there are almost negligible studies or case reports regarding that. Almost nil reports regarding the periodontological aspect. Thank you.
And remember,
already we had few questions in that Google format. No, I have sent to you.
Yeah, one moment.
Shall we take a?
Yeah, it's up to you, ma'am. I mean, if you want to take
more like essay type questions. No?
Yeah, that's what I said. That after reading, I was a little amused. I said, each question is like geriatric nutrition. I took a 1 hour lecture in our pre-examination seminar that we had for postgraduate students. There was a 1 hour lecture on nutrition. So each topic is so vast. But nevertheless, I have given my email ID. You have my number, and anytime anyone wants to discuss anything, please feel free. This is my passion, and I can, really, I can arrange a lecture on the telephone also. That's not a problem.
Someone has asked, are there any specific causes pertaining to geriatric dentistry? I don't know who that person is.
No, it's a good question. It's a very good question. The thing is, to my knowledge, till today, about IGNOU, maybe Manurati madam knows better, but I don't know to this date about any hands-on courses that have been held on geriatric dentistry. Leave aside any training programs or anything like that. The need of the hour is that we really have to hold such courses, and that to really, because we at least we need to train the clinicians who are going to face geriatric patients. That is the young clinicians, they will face them more and more. So we need to have such programs. That's why I always, complain to Manurati ma'am, do something so that, in academics, we must have this particular subject. But I will tell you, there is this course run by Geriatric Society of India, which is on geriatric medicine. It is on, yeah. Yes, ma'am.
Madam very rightly said she has attended that course. Though, first I put a disclaimer. I am not putting any other platform. I think this platform should not be used for any other organization. So this is my disclaimer. But as Madam mentioned, the courses available, one Madam talked about the IGNOU Open University courses. And what Madam in the CV also, I learned that the geriatric medicine. I think Madam, you attended the second certificate course. And
no, the first one, first batch, ma'am.
And currently the third edition of the same has started.
Correct.
I am the faculty member for that, and I may share it with you. Today was the first lecture, and when your lecture was going on my mobile, I was attending that because that is 1.5 hours, two presentations. One on geriatrics, one on ageism and social responsibility side by side. So I could not see the slides. So that is the one. There is a disclaimer that I'm not promoting any other organization over here.
But nevertheless, it's a good course. So I learned my fundamentals and I got inspired because I did this course.
Around
so
29 courses, the lectures that happen every Tuesday and Thursday, 8 to 9:30 p.m.
That's right, ma'am.
That has started on 20th of September.
Yes.
9th of holiday, so it started on 20th of September. Thank you.
So, ma'am, do we get a certificate based on geriatric dentistry?
No, not geriatric dentistry, geriatric medicine, ma'am. Manju, ma'am, this is a geriatric medicine course. This is a foundation course to get to know your geriatric patient and all the problems that you face.
The brochure which I attended, if it is visible, let me.
Dr. Manu is trying to.
I will share it. I will share it with Manju, ma'am, and Shamon sir and Rupesh, and you can
share in our IPS group.
Yeah, I will share it with you.
Certificate course in geriatric medicine and gerodontology version 3. It is being organized. This version is by GSI, Geriatric Society of India, and Khaza Banda Nawaz University.
Okay.
Okay. Thank you.
Yeah.
And Dr. Smita, one question is on Parkinsonism. Geriatric with Parkinsonism.
Correct.
What are the riders?
Yeah. Actually, with Parkinsonism, sometimes I have faced bitter failures. That is because of the very, poor muscle support. And what happens is Parkinsonism goes hand in hand with Alzheimer. So many a times it so happens that unfortunately, the condition comes to that stage where the patient is unable to wear the prosthesis, maintain the prosthesis on his own or on her own. And even the caregiver becomes very helpless. So Parkinsonism is one area. Of course, in early stages, you can counsel the patient or you can make the patient do exercises and all that. But gradually it increases. And if it gets complicated with Alzheimer, then you cannot expect success in that.
Yes. Okay.
At least I have been defeated many times with Parkinsonism.
Many cases with Parkinsonism now.
Yeah, that's true. And, all these patients, they come to hospital settings.
Yes.
So we face them more. All the complications we face a lot because, ultimately they are sent to the hospital. That's why.
Yes. So no further questions I can see on my screen. Students, so shall we close this session? Dr. Sudeep, would you like to add something?
Yeah.
It was a wonderful talk, ma'am. It was really great. And I think one more point is to be stressed is about psychology of the patient, right?
Yes, absolutely. Definitely. Because as I said that, this is again, we are opening topics after topics. The questions that are coming up, you can understand that we are opening topics after topics for discussion. And all these really need to be addressed. I'm very glad people are pointing it out That means there is so much of need to understand, to learn about these things, and then to learn about the how to handle the patients with such problems.
And as you stressed, the first appointment, you have to talk to the patient. You have to understand the patient, the patient's family history, all the histories you have to understand. That's very important. Usually tell my PGs about that first. I don't tell them to do the treatment first. You just have a talk to them, have a good rapport with them first.
Excellent.
I think that is the best.
That and of course informed consent. That is another thing that has to be stressed.
Very important.
Yes. So thank you, ma'am. Thank you so much for your very, very knowledgeable talk. And it is really wonderful. Thank you.
As I said, sir, this knowledge is the Ekalavya method of learning. You learn by your practice. So the way Ekalavya learned, I learned the same way. So, my patients are my gurus. So I learned from them. And a real nice celebration on Gauri Pujan. This is a memorable Gauri Pujan I have ever had. Thank you so much. Thank you.
Great. Thank you. Thank you, ma'am. Thank you.
Some closing statements, sir.
So before moving to that concluding remarks, I request Dr. Rupesh to hand over the certificate to ma'am, the speaker, our eminent speaker, Dr. Smita Alwale.
Thank you so much.
Thank you, Smita. It has been an exceptional, extensive, talk. I'm sure it would have opened, a lot of young minds who listen to you today. This facet of dentistry has probably, been avoided or been, not looked into. So I'm sure you have given us a lot of food for thought, especially the younger generation. Old age is such a thing that, growing old is like being increasingly penalized for a crime you have never committed. It's been something like that. So I'm sure that population has to be addressed to. And Smita, thank you so much for being with us today.
Thanks,
and as promised yesterday, Dr. Manju, Sudeep, we will have an offline program, where Dr. Manu and you can help us, the FICD, together we can work out something, addressing various aspects, like you said. We'll definitely look into that aspect, and I'm sure Dr. Manu also will assist us in conducting this, and kindly accept this certificate as a token of our love.
Thank you so much. It's been an honor. Thank you so much. Thank you.
Thank you, sir. So now I request Dr. Sudeep sir to hand over the certificate to our moderator, Dr. Shyam Mohan.
Yeah, I think Dr. Shyam Mohan did a very nice job, and congratulations for coordinating this program. You did a wonderful job.
He can
Please accept the certificate. Please accept.
We meet tomorrow.
Thank you, sir.
We work together, that's why. Me too.
We will send you a hard copy, okay, Smita, to you also, not just Shyam. We'll be sending you also.
Yeah, thank you so much. Thanks for that. And it's so, it was so comfortable having Dr. Shyam Mohan along as a moderator, I tell you, and it brings back so many pleasant memories that we have had over the years, as Madam was saying, over 2 decades maybe. So wonderful.
Manju. Yeah, when Manju called me for this, I said, yeah, is it Smita? It's a pleasure to share this. Yeah.
Wonderful. Thank you so much.
And one last query from me to you.
Yeah.
Is Rajnikant geriatric?
As I said, it's all in mind, sir. If I call him geriatric, I think I'll be murdered.
In fact, Shyam, somebody, an old age 83-year-old person asked somebody whether I can do a rock and roll, a rock and roll English song I want to perform on stage. So somebody said, look at Mick Jagger. Mick Jagger is a living example.
Exactly. Yes, true. So it's all in the mind.
Absolutely.
It's all in the mind.
It's all in the mind. It's all
yeah. Bring the Rajnikant out of your geriatric patients. That's the message.
Rajni is still Rajni, right? He's our hero. And so is Mr. Amitabh Bachchan. Epitome these people are. Yeah, absolutely. Who will call them geriatric? Never.
Sir, can I take a moment to thank my dear friend, Dr. Rupesh, such a dynamic personality. Thank you so much, dear Dr. Rupesh. Thank you so much.
Pleasure.
I thank all the delegates, and I would like to share that though here I am representing FSCD, but I am no less a member of IPS. I am doubly happy. I am equal part of Indian Prosthodontic Society and equal part of the Board of Geriatric Dentists.
Yeah, true. Same here.
Thank you so very much. Thank you, everyone.
Thank you.
Thank you.
Thank you. Thank you.
Thank you, Dr. Manu, for your presence too.
Thank you.
Before winding up, so a concluding remarks. So on behalf of Kerala Prosthodontic Society, we extend our heartfelt gratitude, ma'am, to her profound insights and wisdom in this field. Ma'am's expertise and dedication in this field is truly remarkable, I should say. See, actually, I'm sure this webinar inspired many youngsters to work in this field of geriatric dentistry. Thank you, ma'am, for your informative and inspiring session. Thank you so much. Again, once again, a big thanks to that organization, Federation for Special Care Dentistry, Manu Reddy ma'am, and the entire team for doing a fantastic job.
Yes.
And our moderator, our family member, Dr. Shyam Mohan, for meticulously moderating this session. Thank you, Dr. Shyam.
Thank you, Manju.
And thanks to, a big thanks to all the delegates. I think
that's very important. Yes.
50, 60 participants are there. So big thanks to heads of the department, then all the faculty members and the postgraduates who actively involved in this session. Thank you once again. Then thanks to our EC members for their valuable suggestions and the support, timely suggestions. So thank you one and all. Thanks to all. So thank you.
Thank you. Thank you.
Thank you and good night.
Thank you and good night. Thank you.
Good night. Thank you.